All right, well, welcome back to Ultrasound Grand Rounds this week. I'm excited as always to be here with you. Continuing on in the fall, it is, as we do this, now approaching mid-November. It's hard to believe that we got through September, October, and now half of November already, and we're here. But today we're going to come back to some more ultrasound stuff, and specifically cardiac ultrasound. So last week, if you remember, we talked about the 5 E's and the 5 C's, right? So we had this lecture basically talking about the 5 E's of echocardiography, and we viewed that in the context of 5 specific cases. And what was interesting is one of the comments that I got back when we had kind of the open comment section, which, we don't publish on the YouTube channel, but one of the comments that I got back was, hey, this is all well and good, but hey, I'm struggling to kind of keep up with what window is what window and kind of how do I put the basic pieces together? And so this fall, what we've been focusing on is getting back to some of the basics of bedside ultrasound. And so what we're trying to do here is kind of get into, some of those, very foundational things. And so I'm going to take a step back today, and we're going to talk about the cardinal cardiac windows of bedside echocardiography. There we go. Switch over to that screen. So we're going to go even more basic than what we did last week. So last week was kind of an interpretive framework. So once you got the image, how do we think about it in terms of a clinical context, and how do we then use those findings on each image that we see and interpret that, from a patient-oriented perspective. Right? We didn't really think so much about, well, what window do we need to capture? We thought about, once we got our data, how do we look at that? What are the things that we want to see? And we talked about, like I said, the 5 E's, the 5 C's. We talked about the entrance. We talked about the exit. So we talked about, IVC and the aorta. Those are the last two. We talked about the effusions, whether or not there's fluid around the heart, how well is it squeezing with an ejection fraction. And we talked about equality. So right side versus left side. And is there evidence of like right heart failure, right heart strain, and things like that. So as we put all these pieces together, these are the questions that we're going to answer as we think through our bedside echo. But we want to back up. We want to talk a little bit more about some basics today. So with that being said, our objectives today is going to be this. We're going to talk very briefly about machines, probes, patients, kind of how do you just even approach the room, right? What do you do when you bring the machine into the room and get started? And sometimes that's the hardest part of like, I just need to get to the bedside and start, right? And then once we've done that, right, then we're going to talk about each of the 4 cardiac windows, 1 IVC window. So 5 different windows that are important when we do our bedside cardiac ultrasound. We'll discuss a little bit of the anatomy, right? What are we seeing in this image? And then we're going to discuss what each of these different images are good for seeing, right? So when I'm approaching the patient, say, I want to know this, right? When I want to do E number 1 or E number 2 or E number 3, what windows do I need to be thinking about as I start putting this piece together? Or if I have one window here, what window is complementary so that I can start getting a 3-dimensional understanding of what's going on with this patient's heart. So that's the goal of today. Hopefully at the end we can wrap it all up together and say, here's a nice package of the 5 different things you want to think about when you go to the bedside as you're collecting the images, and then you can review last week's lecture, and it's going to be about the 5 things you want to think about as you're then taking all that data and synthesizing it for patient related decision making. So as always, these lectures are going to be, they're being recorded, right? And they're going to be published on our YouTube channel, MetroHealth Emergency Ultrasound on YouTube, where you can go back and watch them again. If there's particular areas that you thought were helpful or wanted to go revisit, you can go see that. While you're there, hit the subscribe button, hit the notification bell so you can get these in your inbox, and you can know when we're putting these out. And we're a couple weeks behind in terms of creating the videos, but we're going to get these up over the course of the next few weeks so that you guys can go back and revisit these. So with that said, let's dive into probe and machine settings. So when you wheel in your machine into the room, right, you say, I got to do a bedside echo for whatever reason, right? And there's a myriad of indications for doing a bedside cardiac ultrasound, whether it be the patient's hypotensive or they're, tachycardic, or there's a trauma, or, you name it, right? There's just a 1,000 different ways that you can get yourself into this scenario, right? And so you're going to walk into the patient's room, right? And you're going to have to set a few things up on the machine, right? The first thing that I think we need to really kind of get into is the conventions that we're going to use as we use our machines, right? And I was thinking about this on the way in today, and part of me wanted to just have some fun with this part and talk about the medical version of multiverse theory and how cardiology and radiology exist in two different universes when it comes to echo and orientations, and how we as emergency medicine have to be this third universe, and we have to take the best of it was kind of cool, but it was going to take too much time. So with that being said, and all joking aside, cardiology has a very different convention from how they do ultrasound from radiology, right? So on the left, you see a nice smiley, happy picture of a baby. And this is in radiology convention. If you see the circle up there in the top left, the probe indicator is on the left-hand side of the screen, right? Whereas on the right-hand side of our window here, you'll see an echo, right? A heart, and you'll see that same probe indicator, but it's on the opposite side, right? It's on the right-hand side of the sector, right? The ultrasound sector. And this is because radiology and cardiology have two different orientation conventions when they do their ultrasound. Radiology to the left, cardiology to the right on the screen, right? And as we remember from our basic physics ultrasound lectures and knobology lectures, that probe indicator corresponds with an indicator on the actual physical ultrasound probe, right? And so whatever's towards that indicator is going to be towards the dot. Whatever is going to be away from the indicator is going to be away from the dot, right? And so what we have to remember is that we have to orient our probes in a certain way when we're in our cardiac, quote, mode. And so if you want to put some language around this, okay, we can actually make it go live first. So you can kind of see this smiley, happy baby and this, nice, happy heart. But if we put some language around this, in radiology convention, right, our probe indicator by convention is going to go towards the patient's right-hand side, right? Not our side is a sonographer, right? The patient's right-hand side. And if you're in the long axis to the body, towards the patient's head. By contrast, when you're in cardiology convention, we're going to flip that, right? The probe indicator is going to go towards the patient's left-hand side and go towards the patient's head. And the way you can remember this is sonographers, radiologists, usually come in and they wheel the machine to the right-hand side of the patient's bed, right? And they scan with their right hand, and they do the machine manipulations with their left hand, right? When you go watch the echo techs, right, the echocardiographers, they go in and they say, hey, look, our organ system primarily lives on the left-hand side of the patient's body, and so we think the left is the most important direction vis-a-vis the patient, and so we're going to put our machine on the left, right? We're going to scan from the patient's left using our left hand as a sonographer to put the probe on the patient's chest, and we're going to use our right hand to do the machine controls. And before we think that it's just some sinister ploy to screw up all the right-handed individuals, it makes sense. Like if you have to position the patient towards you, right, it's easier to reach kind of with your left hand to the patient rather than reaching all the way over, with your right hand across the patient. And so it makes a little bit of sense how they get into this from just their unique perspectives on where their organ systems are. But what it requires of us is just to remember that when we use a cardiac mode, right, when we use a preset on the ultrasound machine that's built for cardiac imaging, it's going to put that dot on the right-hand side of the screen, right? Which means we have to just flip the orientation of the probe in our heads to patient's left and to the head, as opposed to the patient's right and to the head that we would normally do for basically all of the forms of ultrasound imaging that we do at the bedside. So that's kind of the first big point about cardiac ultrasound, right? Now, when it comes to actually looking at the machine, this is a picture of the display of one of our machines. The first thing we're going to do when we get in there is we're going to obviously identify the patient to the machine and all the requisite steps to do the workflow, but we need to select the proper probe, right? And the proper probe is going to be our phased array transducer, right? And so the phased array is great because it's got a narrow footprint. It gets in and out of those rib spaces really, really well, and it's what we use for our cardiac ultrasound, right? And then once you've selected the probe, then you need to tell the machine what you intend to do with it, and by that I mean you need to select the cardiac preset, right? And we've got a couple different cardiac presets on our machines, and I imagine the machines that you guys use will have a cardiac preset. And what it does is it takes all the different machine settings that really help you optimize the cardiac ultrasound, and it sets those for you, much like the seat preset in your car. You hit the number 1 button and your seat goes to where you want your seat, where you want your mirrors, the height, the distance, all those things. It will set that up for you in the proper context when you're doing a cardiac ultrasound, right? And so that's going to be our machine and our probe, selections, and how we choose kind of where we, the study that we're going to do and kind of where we put ourselves. Now, most of the time when I scan, I position myself to the patient's right, and I just have to do that reach. But I also remember that I need to move that probe indicator towards the left, when I'm scanning. Excuse me. Scanning in cardiac mode, right? The next thing to talk about briefly before we get to the different windows is our patient positioning, right? And so this becomes really, really important because we can really optimize and enhance our windows based on how we position our patient. And so most of the patients that we see are going to be either in the supine position or the kind of semi-recumbent, semi-sitting up position, right? And that can be helpful. It's convenient, but unfortunately we have a very, very small space that we need to identify to look at the heart, right? If you remember your anatomy, you have the heart that's kind of buried in the mediastinum, and on either side of it, flanking that heart, you have two different lungs, or two big lungs. And those lungs and the air in the lungs really work to defeat the ability to see with ultrasound, right? They block the ultrasound and we can't see through them. And so you have to find this small little window, right? Remember that lingula of the left lung? There's a little window there where the heart pericardium approaches the pleura on the outside, well, not the pleura, but the chest wall, and we can get a little bit of a cardiac window in there where we can see kind of underneath and through that lung, right? And so we have to find that small little space. And that can be challenging, right? And so if you are struggling seeing with the windows that you need to see when the patient's lying supine, one of the things you can do is what we see on the right-hand side of the screen here is just roll the patient over to the left side. And what that's going to do is that's going to pull that lung down. It's going to exaggerate that little window around the lingula and allow us to be able to have a larger space where we can see the heart, right? We can get in and out of those rib spaces to see kind of where that heart is kind of behind all those structures that block the ultrasound. So from a patient positioning standpoint, if the situation allows, and I know that some of our listeners work in the ICUs and they have patients who are on the ventilator and multiple drips and central lines and they're in restraints and all sorts of things that preclude the patient from really moving too much, right? And so to do a positional reposition the patient can be quite the ordeal. And so sometimes it's not as feasible as others, but if the patient's awake and alert and talking and just sitting in the bed, oftentimes having them roll onto their left shoulder, right? And not just kind of like this semi kind of just kidding, I'm trying to roll, but no, like a legit roll onto your left shoulder will help open up that space, make that window a lot bigger, so you'll be able to see a lot better, and you'll be surprised at how much that's going to help you as you're scanning your patients, right? So with that said, that's our patient and machine, or our probe and machine settings. We talked about the patient positioning. So let's dive into the different windows, right? There's 5 different windows that I want to talk about today. 4 of them the heart, 1 of them the IVC, that are going to help us as we kind of get a 3-dimensional perspective on the heart. And I think that's one of the unique things as we think about the heart compared to a lot of the other structures, is it's such a dynamic organ system, right? And so if you look at a liver, right, it just sits there, right? The thing is, it's big, it's kind of homogeneous. The interesting stuff around the liver really happens around the liver. I apologize to Sandy, who gave a spectacular liver ultrasound. So if you want to find out, or liver ultrasound lecture, if you want to find out all the cool things that can happen in the liver, go back to the YouTube channel, find that one, some pathology of the liver, great lecture. But just to extend this analogy, it kind of sits there. And so, you can look at it from different perspectives, but it's not really dynamic. Whereas the heart, it is constantly moving, right? And there's so many things, like we talked about last week, that can fail, right? Or that can work improperly, that have unique impacts on what the heart does. Or the other interesting thing is there's so many things around the heart that can affect how the heart works. And so if you want to get into some really cool physiology, think about the pulmonary physiology, specifically pulmonary hypertension, the 5 different types of pulmonary hypertension, and the effects that has on the heart, and the things that you can pull out of the heart in terms of echo findings to really dive into the details of pulmonary hypertension. Like you can get yourself really, really deep, really, really fast. But it's an example of how dynamic this thing is. And so as we approach the heart, we need to have, these different windows to look at it, different perspectives, different angles, almost as if you're taking, something and you're analyzing it from the front and from the back and the top and the bottom to get a full view of the heart. And, in radiology parlance, they say 2 views is one is none, right? You always want 2 orthogonal views of something that's going to get a full view. And I think the heart is no exception to that rule. There's a lot of things that you may miss on one window only that you need the other windows to see, right? If you're looking for wall motion abnormalities, or you're looking for ejection fraction or effusions, like you may miss it in one particular window and pick it up in another. And so having these 4 different heart windows, an IVC window, are very, very helpful. So let's dive in. Parasternal long axis. We talked way too much about kind of the things leading up to it. So parasternal long axis window. This is one of my favorite views. And so as we're thinking about this from a conceptual standpoint, there's 2 parasternal windows, right? And 2 4-ish chamber windows that we're going to talk about. So parasternal long axis is one of them. And so here's just a nice, beautiful example of a parasternal long axis window. And we'll dive into some of the details here, but we wanted to start off with just a video clip to kind of catch your eye and say, this is what we're looking for, right? So if you go to more of a model perspective, right, the parasternal long axis window is going to be viewed from the sternum, like from the chest wall, anterior chest wall, right, as its name implies, parasternal, so just alongside the sternum, and it's going to be kind of in this oblique orientation relative to the patient's surface anatomy, right? So the probe indicator will go towards the patient's head or shoulder, right? And then the other end of the probe indicator will be kind of going towards their hip in kind of this long axis view. And so when people ask me like, hey, what angle do I need to put it on? Say, just imagine the heart in the body, right? Look at the patient, right? The heart's going to sit at kind of an angled orientation under the sternum and just off to the left of the sternum. And that's why we put our hand over our heart when we want to feel it beating. And you can see that thing, you can imagine the thing going kind of in that oblique orientation. So probe indicator towards the shoulder, in that oblique orientation from right shoulder to left hip, right? And that's going to be kind of roughly where we go to find this view. And so going back to this window here, we have a little bit of a schematic on the right where you can see kind of where we're at, and then you can see the parasternal long axis view of this patient, this particular patient here. And so let's put some labels on this here. Let's get some more information of kind of what's going on in this heart right there. Perfect. And so the beautiful thing about the parasternal long axis window is it gives you a lot of information, especially when you come down to the 5 E's and the different things that you want to see when you're looking at the heart. And so I just made a list, right, of all the different things that you can see in the parasternal long axis window. And so if you think about it from the direction of blood flow, right, starts in the left atria, right, goes through the mitral valve, right, to the left ventricle, comes out the left ventricle through the aortic valve, right, and then you have the aortic root, and then you can see things around there, right? And so I think from a conceptual standpoint, it's helpful to know that the parasternal long axis window really emphasizes that left heart, right? And that's the primary driver of the cardiac function, right? It's what we get our afterload from. When we talk about the different parameters of cardiac physiology, right? So the parasternal long axis window is going to be a great initial, pretty decently easy view to get when you want to say, okay, generally speaking, what's my left heart doing, right? And we can see that left atrium, you can see that valve that's kind of flapping between the left atrium and left ventricle. There's a little cord, and unfortunately, I don't have a cursor that I can put on there, but there's a little cord that connects that valve to the left ventricle. That's the chordae tendineae with one of the papillary muscles. Right, it's a great view. You can see all that, the left ventricle, and then you can imagine that left aortic outflow tract with the aortic valve just underneath that A on aorta, and it's a great view, right? It gives us all that information. Now you can see the pericardial space. In fact, it's a great view of pericardial space because where the arrow is on this pericardium, that's a gravity-dependent area, right? And so if you're going to have fluid inside that pericardial sac, it's going to collect in this gravity-dependent area, right? It's going to collect in the posterior aspect of that pericardial space, right? So it's a good view to see that. You do see a little bit of the RV, specifically the right ventricular outflow tract, right? And so one of the misnomers of this view is that, like, oh, this is the right ventricle. No, not really. It's kind of the anterior portion, of the heart. And if you think about it, the right ventricle is kind of, it's there, but when you get to the anterior part, it's that outflow tract as it's going up towards the pulmonic valve, right? And so it's not the full RV. It's not one that you can do a great, RV to LV ratio size on. It doesn't give us a lot of RV information in this particular window. So you have to take that with the grain of salt. That's why we have other different windows that we want to look at, right? Now, one important landmark feature that we see here is that descending thoracic aorta, right? And so this becomes really, really important when you're discussing effusions, because if you imagine the pericardial sac, right, lives above it, right, lives above that descending thoracic aorta. And so if you see fluid above that descending thoracic aorta or transversing across the descending thoracic aorta, that's going to be pericardial fluid, right? Whereas pleural fluid, right, you can see that left hemithorax, it's kind of just going to be deep to that pericardium. In fact, you can see those vertical lines extending from the pericardium. That's B lines of the lung that's just adjacent to that, right? And so this is pleural space. You can see pleural effusions there. And if you have fluid in the pleural space, it's going to come up to that descending thoracic aorta and it's going to stop, right? It's going to not go over, but it's going to stop at that descending thoracic aorta. And so it's a really important anatomical landmark or guidepost that will help us as we start piecing together, okay, I see fluid, but where's this fluid coming from? Where's it at? Help me understand this one. So this is the parasternal long axis window, a great window, to do things. And so I wrote down a list of things, here's kind of some of the good things that the parasternal long axis window will do, right? It gives us a great view of left heart function. We talked a little bit about that, but you see all the different components of the left heart, right? Left atrium, mitral valve, left ventricle, left ventricular outflow tract, you see the aortic valve, you see the aortic root. Like the whole thing is in one different window. And you get the additional benefit of you get to view of the pericardial sac, right? You can see that gravity-dependent space in the pericardial sac. That is going to be the important part, like we talked about last week, for identifying pericardial effusions. Now, when you want to look at the effects of the right heart, so if there's any evidence of tamponade, this is not your view, right? It does not do a good job on the right heart, and so you're going to have to get other windows. But if you're looking specifically on the left heart, you can check out the valves, you can check out the outflow tracts. If you're looking for like SAM physiology for patients with HOCM, you can see that septum right there. You can see if the mitral valve is being sucked into the aortic outflow tract during systole. There's all sorts of great information in this view, and it's pretty decently easy to get as you position your probe on the sternum, right, just to the left of the midline, right, in that second or third intercostal space, right, with the probe indicator oriented roughly towards the patient's shoulder. You have to do some adjustments when you get there, but this is going to be a great view for those different things. So a couple pathology examples. Here's an example of a pericardial effusion. This is a really, really small one. You can see it's still there when the heart when it's in diastole, but it's pretty small. If you want a little bit of a bigger one, here you go. So this is a patient with a longer standing pericardial effusion that's a little bit larger. You can see that fluid that collects and tracks anterior to and across the descending thoracic aorta, signifying that this is pericardial and not pleural fluid, right? So great view of the pericardial space, the left ventricle, left atrium, the left side of the heart, for all intents and purposes for this particular window. So that's parasternal long, right? With that said, let's move on to the parasternal short. That's gonna be our next window that we want to talk about. And so when you do this one, right, you've already found the parasternal long, right? So here's an example. It's just kind of a, catch your eye. This is the donut view, right? Makes you kind of hungry. When you do your parasternal long axis window, right, you're already in the right place. You found the window, you found that spot that you can get access to the heart. All you have to do to identify this one is turn your probe 90 degrees. So your probe indicator goes from one shoulder, right, goes from your right shoulder to your left shoulder, right? So you're going to do an orthogonal view at that spot on the chest wall to find the parasternal short axis window. And this window is, I like this window, right? I particularly, it's not, I don't know if I could say it's my favorite window, but I like it, and I've heard a lot of people kind of trash talk the parasternal short, like there's not a lot of stuff here and you get everything else in other windows, and okay, fine, you get a lot of information in other windows, or that you get in other windows, but it's kind of a nice view to look at a few different things, right? And so one of the useful things about the parasternal short is you can use it to look at various different places in the heart, right? You can almost like you're if you're taking, a carrot or cucumber or something like that and chopping it, and celery chopping or cucumber chopping or carrot chopping, or however, whatever vegetable you want chopping, you can kind of slice through the heart at different levels. And each level gives you kind of unique and interesting information. But roughly speaking, the parasternal short should look like a donut, right? It should be round and symmetric, and the walls should collapse, or should not collapse, but should like contract and thicken symmetrically around the circumference of the left ventricle. And so in this image, you can see basically that donut. You can see the two papillary muscles with that schematic of where we're looking at in the heart and on the chest, right? So kind of in the same vein as what we did with the other window, the parasternal long, here's just a list of things that are commonly seen in the parasternal short axis window. So a great view of the left ventricle. It kind of centers up on that left ventricle. Depending on what level you're at, you can see the papillary muscles, you can see the valve, you can see other things. In fact, the next couple slides will show those. But specifically at this level, you can see the left ventricle. Off to the left in kind of in the near field on this particular image, you see another echo pore space. That's going to be the right ventricle, right? So the right ventricle will be attached to the side of the left ventricle. So you can get a little bit of a view of RV, LV size ratios. Not the best window, but you can get a little bit of a view there. And then deep to all that bright white curved line kind of just deep to the left ventricle is the pericardial sac, right? And then you obviously have the pleura deep to that. And so you can see pleural effusions here. You can see pericardial effusions here. It's a great window that I'll oftentimes go to when I want to confirm, like, hey, I think I saw some pericardial fluid. Let's flip to the parasternal short. Let's see if I can identify it again in the parasternal short, just to confirm that this is what's going on in this particular window, right? The other thing that I find is helpful for the parasternal short is you can see, like I said, thickening circumferentially around that muscle, and so it's helpful to see if you're trying to identify, any electrical, dysrhythmias. So you'll have dyssynchrony if you have like a bundle branch block, or you can use it to see if there's any like regional wall motion abnormalities from ischemia. Again, you have to interpret in the context of have they had that before or anything like that. So, but if you're looking for like new ischemia, you can see, sections of the wall that may not be working, and then tie those to a vascular territory when you're looking at what vessels supply what part of the heart. So this is the low view, right? You can see the papillary muscles, those two little globs kind of on the left and right of the left ventricle. As we kind of fan up a little bit further, kind of angle up a little bit north towards the patient's, towards the base of the heart, you can get into the mitral valve area. So it's a great view. Again, you have the left ventricle there, but you see the mitral valve annulus and the mitral valve leaflets kind of as they open the bileafed mitral valve. And then if we go even further north, right, kind of angle that up a little bit more towards the base, we find the aortic valve in the center. You can see that kind of right in the middle of that hub. And then you have the right ventricle or the right side of the heart that wraps around it. So the chamber to the left is going to be the the right atrium. You'll see the tricuspid valve. That's the kind of flapping valve to the left there. And then the right ventricle is going to be on top. And as you get towards the top and move over towards the far right on this screen, you get towards the pulmonic valve, which is not clearly seen in this window. And then eventually you'll have the pulmonary trunk that kind of wraps around, showing kind of the right-hand side of the heart as you kind of scan up north on that short axis view. And so what's this view good for? It's good for a lot of good things, right? You can see fluid in the gravity-dependent pericardial space, right? It's going to be in the deep far field, kind of in that pericardial space. It's good for looking for wall motion abnormalities like we talked about, right? You can use it as kind of getting you started looking to see RV, LV size ratios, right? It can be helpful there. You can also see if there's any evidence of RV strain, right? And so when you have RV strain, you increase your pressure in the right ventricle. It's going to flatten out that septum. And so the septum should look like a donut, or the whole RV should look like LV in this view should look like a donut. But if it starts looking more like a D sign, you have a big RV, you have to start being concerned about increased pressures in the right side that's going to flatten out that septum and put pressure on the left ventricle. So there's that view. And it's also, you can use it, not the most ideal window, but you can use it to look for some valvular insufficiency if you're up in the mitral valve region or if in the aortic valve region, in particular, some Dopplers. So there's a lot of potential uses for this particular window. window. Looking at some pathology, here's an example of the parasternal short at that mitral valve view. So you kind of see that fish mouth view with the mitral valve opening and closing, and a pericardial effusion kind of in that's kind of wrapping around, but definitely in the deep far field of this particular patient's ultrasound window, specifically right there. It's a really good window. Actually, you see it's a really good definition of that RV wall because that effusion in this particular window. So here's an example of some septal flattening, right? You can see how, instead of looking like a round donut, it just kind of the pressure of the RV is just kind of pushing on that septum, flattening it out into the LV, suggesting that's increased pressure there. And if you want to go a little bit more esoteric, a little bit more complex, if you do the 60-60 sign for PE, we got a video on that on the YouTube channel. But if you do the 60-60 sign, you want to get a pulmonary outflow tract Doppler to look at that acceleration time. It's going to be up here, right? You're going to go in the parasternal short, really high up by the base as you're getting that, the blood coming out of the pulmonary outflow, or the right ventricular outflow tract into the pulmonary valve. You're going to do a Doppler there to get your acceleration time. So a couple different views that you can use, or a couple different reasons you can use a parasternal short, right? So that's PSLA, PSSA. Now we're moving on to our 4-chamber windows, right? And the first one we want to talk about is the apical 4, right? This is probably one of the harder windows to get, but it gives you the most information probably of all the different windows, largely because you see pretty much everything, right? You get a great view of the entirety of the heart. And we'll talk about that here in a sec. But if you want it from a schematic standpoint, we're angling our probe down at the apex of the heart, right? Where the heart is adjacent to the chest wall. In fact, they talk about the point of maximal impulse when you do your exam, right? It's going to be roughly in that space. And so I find, seeing as how most patients with everything from an MI to a stub toe get an EKG, the thing that I'm probably going to be, that's probably going to happen before I get to my patients, they're going to have a 12 lead. So I find if you go to the patient's bedside and identify that V3, V4 sticker region, right? Pull those stickers off. Somewhere underneath one of those 2 stickers is really going to be the spot that you want to go to when you're doing your ultrasound, right? You're going to put your probe kind of in that spot, angling up towards the shoulder. So you're going to angle now kind of in that oblique direction, probe indicator towards the patient's left-hand side to give you an image that looks a lot like this, right? And so what we want to see in this window is we want to see the heart vertically oriented, right? I want to see put the tip of the sector, or put the apex right in the tip of that sector, and then the septum almost vertical, as vertical as I can get. And I want to twist my probe such that I can open up the ventricles to see their full width, and I can know that they're in the full width because I see the 2 different valves opening roughly simultaneously, right? And then if it's oriented properly, right, the left ventricle will be on the right-hand side of the screen, and the right ventricle will be on the left-hand side of the screen, right? And so we can see this is kind of where the probe should be, roughly on the chest, and the window that we're looking at getting, right? And so what can we see? You can see, like I said, you can see everything here, and I think I put some labels on it. There we go. So we have LV, RV, kind of the 2 big elephants in the room, right? And then the LA and the RA kind of deep to that, right? And so with the heart oriented vertically, left side on the right side on the left, and you see those different chambers. If you flatten out a little bit, you can get into the aortic outflow tract, right? And you can see the aortic valve. And so that's why I say you can see the aortic outflow tract, the apical 5-chamber view. It almost looks like the 5th chamber. There isn't a 5th chamber. It's just that outflow tract and the aortic valve. If you flatten out, and if you don't want to see that, you kind of stand that back up a little bit, and you kind of get back into the meat of the ventricles. Other things that you can see here are all the valves, right? Well, most all the valves. You can see the mitral valve, you can see the tricuspid valve. If you flatten out, you get into that aortic valve. You're not really hitting the pulmonic valve very well in this particular window. You see the pericardial space, right? That's wrapping kind of like an umbrella over the apex there that we're seeing. And then the key structure, again, that's really helpful is that descending thoracic aorta. So if you see that LA on this screen, right, kind of go a little bit to the right and just a touchdown, you'll see this circle, this black circle. That's the descending thoracic aorta, and that tells you that that you're on the left-hand side of the patient's heart, right? There's a lot of other indicators. The left ventricle is thicker. It tends to be more conical shape. The right ventricle tends to be attached to the right ventricle. It tends to be thinner walled. There's a moderator band in the right ventricle. You might see that echogenic band kind of at the apex of the right ventricle. But the descending thoracic aorta is the key landmark that says this is the left-hand side. It's not going to be on the right-hand side. So these are the things that you'll see in the apical window. Now, what's it good for? Like I said, it's good for a bunch of things. You can see left ventricular function. You can see right ventricular function in this one. You can see how well it's beating. If you want to do a TAPSE, right, the tricuspid annular plane systolic excursion measurement with M mode, you use this window to put the calipers over the lateral annulus of the tricuspid valve to give you an idea of what your right ventricular function is like. It's a great window. It's probably one of the best windows for relative chamber size because you can, really see the whole chamber of both sides at the same time. See if it's what the ratio is. And it's a great window to look for valvular pathology because it's the best window of the four to really look at Doppler, right? And let's pause here for just a minute and explain this one. So Doppler imaging is basically some form of display of movement, right? It uses the Doppler principle. When things move towards you, frequencies, adjust upward. When things move away from you, frequencies adjust downwards. And so the machine can interpret that change and display it either as a color or as a spot on a graph, right? And so that's Doppler imaging, right? And so one of the things that makes Doppler imaging more accurate is when you align the beam of the ultrasound with the direction of movement, right? If you're at 90 degrees from the direction of movement, you're not going to get any appreciable movement because it requires some trigonometry where the cosine of an angle theta is 90. When you do that math, it equals 0, right? So it cancels out all the calibrations that you do with the trigonometry, right? And so the best way to get movement, to accurately discern movement with ultrasound, with Doppler, is to align the beam of the ultrasound with the direction of flow. Now you can imagine if you're doing blood vessels, that's really hard because you don't have the probe inside the blood vessel. You usually have it perpendicular to the flow of the blood vessel. When you orient things with the heart, you're in the apical 4, the beam of the ultrasound is oriented in this window in the same direction as flow. Now the flow may be away from you or towards you. That doesn't really matter. It's going to show you the color, but it is oriented in the same general direction. And so it's going to be the most accurate way to resolve Doppler changes with ultrasound, right? And so this is a great view if you're going to do any Doppler imaging of the heart. And finally, it's a great view where you can look at pericardial effusions and confirm that, just like you did with the parasternal long and the parasternal short. So a couple examples of pathology here. This is a patient who has increased RV size, right? So the ratio here is clearly greater than 1:1. It's a little over 1:1. And it represents a differential diagnosis that includes PE, COPD, pulmonary hypertension, RV infarcts, things like that, right? So it's a great view for that. And then here's an example of tricuspid regurg on the right, and then measuring that Doppler packet, to give you an idea of what your pulmonary pressures are, right? So it's a great way you can look at some valvular pathology, look at some pulmonary pathology using these windows, or this particular window in the heart, right? And the final window that looks at the heart is this subcostal window, right? And then we'll get into the IVC briefly, and we'll wrap it up. So the subcostal window is, as its name implies, taken below the costal margin, or sometimes called the subxiphoid window, right? And so if you do it from that cartoonish perspective, it's kind of coming in that subxiphoid area, looking up at the heart, kind of oftentimes looking through the liver, kind of up at the bottom side of the heart, right? And so we'll go back to this window here. You can see it's a great view that gives you a decent perspective of the 4 different chambers. You can see some of the atria depending on how you orient your probe in this particular window, and it's a good view to show you the pericardial space. And so a couple different anatomic things that we can see. In fact, I can put some labels on here, just like that. Left atria, left ventricle, right ventricle. Oops, I need to correct that, but it's right atria, right ventricle. Obviously, you're looking through the liver. You can see the pericardium. Oftentimes, you can see some valves. Now, contrast with the other view, it's not the best view for valvular pathology, at least with Doppler, because it's oriented in a very different direction, right? But it shows you all these different things, at least in the 2D image of the heart. And so, what does it do well? It shows you LV function, relative chamber size, looks a great view for pericardial effusion. And it's a good view to have in your toolbox, because when the patient gets sick, right, especially when you're in cardiac arrest, this is the window that's going to be accessible to you, right? Unless you're doing TEE, which again, can be done in codes. Unless you're doing TEE, someone's going to be doing CPR on the chest. They're going to have hands on chest. They're going to be blocking your other windows, right? And so it's a great, quick, easy window if you need just a quick look to see what's going on with the heart. And, in my CPR pauses. So keep that in mind as a reason to go for this window, or when you might want to reflexively go for this window. A couple examples of pathology. Here's a patient with pericardial effusion, right? You can see that effusion. One of the benefits of this window over some of the other windows is the question, like we talked about last week, after you've identified the fusion, is there any hemodynamic effects of that fusion? So this and the apical 4 can give you a view of what the right atrium's doing, what the right ventricle is doing, to be able to know if there's any collapse as a result of pressure, inside the pericardial space, right? We can see that right atrial wall, that right ventricular free wall, very, very clearly on this particular image in ways that we couldn't really see with the parasternal long or parasternal short windows. So another reason to go for this particular window, right? Here's an example of tamponade, like we talked about. You can see kind of some collapse of that right ventricle. And obviously a great view for cardiac arrest. You can see you have cardiac activity on the left and cardiac standstill on the right here. And finally, as we kind of want to wrap things up today, let's briefly hit on the IVC. It's generally included in the cardiac windows because it's, shows you a lot of what the preloading conditions look like for the heart. And so, from an anatomic perspective, things that you're going to see in this window. So this is going to be a long axis window, kind of near where that pericardial or subcostal window is, just oriented in the long axis, right? You're going to see the IVC kind of running down the horizontally in the middle of the image. On our particular image, the right atrium, the pericardial space will be on the left hand of the sector. You can see the hepatic veins coming in. That little stripe kind of inside the liver. And then if you go down a little bit further, you can see the right renal artery. It's going to be the one vessel that runs posterior to the great vessels that signifies that this is IVC and not aorta, right? Not necessarily always seen, but if you see that, you know that you're on the IVC and not the aorta. So couple things regarding IVC and what it's useful for. Really, IVC size and collapsibility are kind of used and plugged into an algorithm to figure out what is my relative CVP or right atrial pressure, right? Central venous pressure, right atrial pressure. And so the general convention is if it's small, you have a low CVP, and whatever that means. Usually it's a volemic thing. If it's large, it's a high CVP, and there's a whole long list of things that we talked about last week that will contribute to that. And so having a chart like this kind of roughly in your head can be helpful. This is off of WikiEM about IVC ultrasound, but there's a lot of resources that'll give you a similar chart. So if the IVC size is really, really flat and there's a lot of collapsibility, in fact, it's 100% collapse, it correlates with a CVP that's very, very low. If it's a plethoric IVC with no collapse, that corresponds with a high CVP, and there's some gradation in between where you can kind of estimate your right atrial pressure. And so a lot of the exact CVP numbers I don't really care about specifically, except when doing like a pulmonary artery pressure. So when you're measuring the pulmonary artery systolic pressure, you need to know your baseline pressure, your CVP pressure, so that you can know what you need to add your delta pressure to get your total systolic pulmonary artery pressure. And so when you're doing that, the IVC window becomes really, really important as you're kind of figuring some of that stuff out. If you're not going that advanced, if you're just looking for general volume status, knowing is it flat, is it plethoric, or is there somewhere collapsible in the middle, kind of gives you an idea of what your relative volume status might be with a lot of nuances and caveats, interspersed in there, but it can give you an idea of relative volume status. So that's the IVC. Here's an example of a very large IVC measured out about 2 centimeters. And if you put some M mode on here, you can see there's just no collapsibility with respiration. So someone that have a relatively high CVP and then can be interpreted in the context of what else is going on with this particular patient. So with that said, brief recap here about the 5 cardinal windows of cardiac ultrasound. We talked a little bit about the radiology versus cardiology convention, what direction you want to put your probe indicator, and how it's going to come up on the presets on your machines. We talked, make them happy there. And we talked about the 5 different windows here. We have the parasternal long axis on the left. We have the parasternal short axis on the right there. And on the bottom, we have the apical 4, the subcostal, and the IVC window. And kind of the reasons, what you see in each of those and reasons why you'd want to select each of those windows as you're coming to the bedside to do your ultrasound. So with that being said, we're going to wrap things up here for this particular lecture. You can see what's on the brain here. And just want to close things out and see if anybody has any questions about anything or anything they wanted to add about these particular 5 windows and things that they found helpful that may not have discussed here. Well, let's wrap things up here today. Thank you guys for joining us, for being part of Ultrasound Grand Rounds this week and usually every week that we do it. I always enjoy bringing these and kind of diving into topics and then interacting on these topics. And so this is probably going to wrap up at least the basics part of the heart. And we'll move on in 2 weeks to some more basic bedside ultrasound. I have to decide if we're going to do kidney or gallbladder first. We'll find something fun. But we're going to continue on this series, basic ultrasound or basic bedside ultrasound, and kind of build some of these building blocks, this framework, this foundation that we can then go back and kind of rewatch and talk about some more advanced things down the road. So that being said, next week, we're not having grand rounds. Next week, I'm going to be doing an ultrasound IV class for one of our satellite hospitals. And then the following week will be the 21st, I believe, November 21st. For those who are live, it'll be some other date for those people who are on the YouTube channel. But we'll be having the next installment of grand rounds just in time to then have the Thanksgiving holiday the week after that. And that will get us into the December holiday season. So with that being said, thank you for joining us today. Go to the YouTube channel, watch these videos again, hit that subscribe button, the notification bell, share them with all your friends. We're really excited about the growth that we've seen here and just the reach that we've been able to have and the impact that we've been able to have in the ultrasound community with these lectures. And so share them with others. Go have a great week. Happy scanning. We'll see you guys next time. Bye.